Hi, this is Rob Leffler. I'm the Vice President of Clinical Services for PCA Pharmacy. I'm just going to cover some of the long-term care regulation changes that are coming up. There haven't been any substantial changes in the regulations since 1991. That's going to change as of November 28, 2016. You may have heard of these changes referred to as the Mega Rule or the New Rule. They opened up a commentary period starting July 16th of 2015. CMS asked for comments on their proposed regulations. They received over 10,000 comments. They reviewed all of those comments and replied to many of them, made some changes to their proposals, and left some of their other regulations as they proposed. There are numerous changes to the regulations that the facilities have to abide by, and they have to abide by them in order to participate in Medicaid and Medicare. As I said before, these regulations are going to take effect November 28th of 2016. That's the first phase. Phase 2 will take effect November 28th of next year, and Phase 3 will take effect November 28th of 2019. There are two big areas that are going to impact pharmacies and long-term care. One of them is the Infection Prevention and Control Program. The other is pharmacy services. This is a list of the many areas the regulation changes are going to affect. We'll talk about Infection Prevention and Control Programs first. This is an extension of their current infection prevention programs. They need to be preventing, identifying, reporting, investigating, and controlling infections. Part of their IPCP has to include methods of dealing with residents, staff, visitors, and other staff providing services such as consultants. Their IPCP should follow national standards. They have not indicated any specific national standards that have to be followed, but examples of organizations that do have those standards are the CDC, Leading Age, and the Infectious Disease Society of America, and there are others that are out there. They have to have written standards, policies, and procedures for their IPCP. They need to be identifying infections, reporting infections, preventing the spread of infections, and providing isolation policies. Part of the IPCP will eventually involve including an antibiotic stewardship program. That is actually not implemented until Phase 2, which is November 28th of 2017. The IPCP also must include a designated infection preventionist. That will be implemented by Phase 3. So they have to have those either by next year or by 2019. When they do have an IP or an infection preventionist, they'll participate in the QA committee. Here are some resources for antibiotic stewardship. I believe that our customers will be reaching out to the pharmacy to support them as they develop these programs. They may ask their consultant pharmacists to be on committees or to review their programs. The pharmacy services changes will actually impact our consultant pharmacists and the pharmacies more. The first area we're going to discuss is the drug regimen review. Actually, all of the requirements that are in reference to pharmacy services are going to be consolidated into 483.45. So the new regulations on drug regimen review will be found there. They're changing the frequency of medical record review to monthly with the DRR. Our consultant pharmacists already do review the medical record monthly, so that really isn't a change for us. Facilities also must have a policy and procedure for the monthly DRR, including timeframes for the process and procedures for when immediate action needs to be taken. There are changes in the psychotropic medications. There are two big ways that psychotropics will be impacted. They've now defined psychotropics, and they're going to regulate the use of PRN psychotropics. Psychotropics are being defined as antipsychotics, antidepressants, anxiolytics, and hypnotics. These are areas that the consultant pharmacists are already reporting to the facilities upon. CMS has said that they may add other drugs to the list of psychotropics through sub-regulatory guidance. With psychotropics, they're going to limit the PRN use of psychotropics to 14 days on any of those psychotropic medications. This can be extended by the attending physician by documenting their rationale in the medical record, except for antipsychotics. Antipsychotics will have to be renewed every 14 days. For the non-antipsychotics, they will, when providing their rationale and rewriting the order, will put a length of treatment with PRN psychotropics. This is not a phase 1 change. This will be phase 2, so November of 2017. With psychotropic drugs, the patient has to be assessed to ensure that if they've not used a psychotropic medication before, they're not given one without documentation of a specific condition that is diagnosed and documented in the clinical record. Any resident receiving a psychotropic has to have gradual dosage reductions and behavioral interventions unless clinically contraindicated in an effort to discontinue them. So they can document that it is clinically contraindicated to discontinue a psychotropic and therefore will not have to do gradual dosage reductions. In the commentary, they are also clear that psychotropics are necessary and the regulations are not intended to completely eliminate the use. The regulations are intended to ensure that psychotropics are not being used inappropriately. Also in pharmacy services at 483.45, they're going to define irregularity. Irregularities were previously referred to in the regulations, but they were not defined. They're using the same definition as they previously used for unnecessary drugs. The medical director will be notified of all irregularities by the consultant pharmacist. That notification will occur in the form of a dated, separate written report that will contain a resident's name, the drug, and the irregularity. This report has to be acted upon. The attending physician must document in the resident's record that the irregularity was identified and was reviewed. They will document the action that is to be taken or the documentation or rationale for there to be no change. They have to develop and maintain policies and procedures for the monthly DRR, and that must include at least timeframes for the steps of the process. For our Trilogy customers, our policy, written in conjunction with them, is for them to receive their report in 1 business day. Steps for the pharmacist to follow if an irregularity is identified that requires immediate action. The Trilogy policy for that will involve direct and immediate consultation with the DHS. In talking more about irregularities, these are defined as excessive dose, duplication in therapy, excessive duration, without adequate monitoring, without adequate indications for use, or any drug that may be causing an adverse consequence, which would indicate that a lower dose or discontinuation should occur. The implementation deadlines, phase 1, November 28th of 2016, that involves the facility policy and procedure concerning DRR and the irregularity reporting. I will be creating a separate communication to the consultant pharmacist concerning this irregularity reporting. We'll be creating 1 additional report that will have a place for the medical director to sign and date so the facility can maintain that they've notified the physician of the irregularities found by the consultant pharmacist. Exceptions to the changes, the medical chart review, psychotropic drugs, so the PRN use of psychotropics for 14 days is actually a phase 2 implementation in November of 2017. If you do have any questions about any of the information provided here or other questions about the mega rule, please don't hesitate to reach out to me. Thank you very much.